Hello, ladies and gentlemen. Welcome to the first session of How I Treat Autoinflammatory Disorders course. I am Dr. Kosa Asnaashari, Assistant Professor of Pediatrics at Children's Medical Center, Tehran University of Medical Sciences, TUMS, Iran, and I'm the head of the executive team for the course. This course is programmed as a progression to How I Treat series, an educational program planned by the leading house for Iran North America academic partnerships of TUMS. The programs focus on a single disease or on one or more distinct aspects of a single disorder, and they offer diagnostic and therapeutic advice by enrollment of international well-known experts in the field. Our course, How I Treat Autoinflammatory Disorders, is comprised of 8 to 10 sessions, held weekly or bi-weekly, and the program will focus on various aspects of autoinflammation, pathogenesis, diagnosis, treatment, patient education, and network development. We intend to provide physicians, pediatricians, immunologists, and rheumatologists with an opportunity to access the latest updates on autoinflammatory disorders. We have gathered elite experts from around the globe, USA, Germany, Turkey, and Iran, to share their knowledge and clinical experience in each session. We hope these endeavors can lead to a better understanding of these newly introduced diseases, which are probably not as rare as they appear. I need to take a moment here and thank Dr. Wahid Ziai, head of our scientific committee, professor of pediatric rheumatology at Children's Medical Center, Tehran University of Medical Sciences, and the president of Pediatric Rheumatology Society of Iran for his full support of the course. We are also very grateful to Dr. Marjan Yaghmai, head of leading house for Iran North America academic partnerships, for her kind support. I would also like to express my gratitude towards Professor Someira Farman Raja, Professor of Rheumatology at Fatima Memorial Hospital, Lahore, Pakistan, and the Treasurer of UPLAR. Thanks to her support and cooperation, our course is now endorsed by UPLAR. Asia Pacific League of Associations for Rheumatology, or UPLAR, was established in 1963 in Sydney. The world-known association of UPLAR strives to propagate and consolidate rheumatology endeavors in the Asia-Pacific region. UPLAR's mission and goals focus on providing state-of-the-art care to the patients with arthritis and other musculoskeletal diseases through the continuing professional development of members, increasing the awareness and understanding about rheumatic diseases, patient advocacy and empowerment, and fostering research in the field of rheumatic diseases. If you wish to receive a certificate for each session of our course, you need to register via Appraise to Raise website. And the link can be found here in the chat forum, and you can also find it in my slides. You can also register for the whole course and receive a certificate of attendance in an international autoinflammatory course approved and validated by Asia Pacific League of Associations for Rheumatology, or UPLAR, Pediatric Rheumatology Society of Iran, Iranian Rheumatology Association, and Tehran University of Medical Sciences, Iran. Today's session is entitled Clinical Approach to Systemic Autoinflammatory Disorders. I am honored to introduce Dr. Fatma Dedeoglu, pediatric rheumatologist at Harvard Medical School, as our speaker. Dr. Dedeoglu is one of the brilliant minds in rheumatology and autoinflammatory disorders field. I'm truly inspired by her work. Dr. Dedeoglu is an associate professor of pediatric rheumatology at Harvard Medical School and a staff clinician at Boston Children's Hospital, BCH, in Immunology Division, providing care for children with autoinflammatory and autoimmune conditions, primary immunodeficiencies, and allergies. Her publication on the largest pediatric series of patients with minocycline-induced autoimmunity was cited among the 50 best articles of the year in Journal Watch Pediatrics and Adolescent Medicine. She has established an autoinflammatory clinic at BCH and manages a wide spectrum of patients with autoinflammatory diseases. She has contributed to the discovery of new diseases, She is also the co-director of Combined Rheumatology and Dermatology Clinic, where she takes care of rheumatologic patients with significant skin involvement. Dr. Dedeoglu is actively involved in the activities of Pediatric Rheumatology Organization, CARRA, that stands for Childhood Arthritis and Rheumatology Research Alliance, and co-led the establishment of the Autoinflammatory Study Group in 2012. She serves as one of the core members of several international autoinflammatory work groups, including ISS-AID, that stands for International Society of Systemic Autoinflammatory Diseases. I should also introduce Dr. Farhad Salehzadeh, Professor of Pediatric Rheumatology at Erdebil University of Medical Sciences, Iran, as the moderator of today's session. Dr. Farhad Salehzadeh is currently the head of the Pediatric Rheumatology Division at Bouali Children's Hospital and FMF Clinic in Erdebil, Iran. He is one of the initiatives and pioneers of modern pediatric rheumatology in Iran. Following his work for 20 years in diagnosis and introducing of FMF patients as a common autoinflammatory disease in northwest of Iran and creating the FMF Registration Center, which included more than 600 FMF patients, today all rheumatologists in northwest of Iran are familiar with autoinflammatory diseases and FMF. I thank you all again for your participation in our course. Feel free to ask your question in the chat section. It is better if you address and send your scientific questions to the moderator, Dr. Salehzadeh, in the chat section. Please make sure to write your correct names, the ones that you have registered with, and please try to keep the chats in English. This way we can communicate with each other better. We will be more than happy to answer your questions, and I sincerely hope that you will have an enjoyable academic experience today. Now, let me welcome Dr. Salehzadeh, our dear moderator, to the stage. Dr. Salehzadeh, we are all ears.
Hi, Kosar, thank you very much. Good starting, I think, and I have to tell something and just some points. First of all, good morning, America. Good afternoon, Europe and Middle East, and good time, the rest of the world. As you know, and all of the world, these days are special days and holidays. So I have to tell Happy New Year, and I wish a Happy New Year and Merry Christmas to all of the world. And as a rule, I consider to say greeting to our special and honor. I'm honored to have Dr. Fatma Dedeoglu today, and giving thanks to some of our supporting groups. I would like to express my sincere appreciation for Pediatric Rheumatology Society of Iran and its chairman and president, Dr. Wahid Ziai, who has made great effort and concerted effort to holding these webinar courses. And I have to thank to Asthma, Allergy and Immunological Research Institute of the Tehran University of Medical Science because of their supports. I give thanks to Dr. Kosar because of her hard working. And basically, she's the driver of the webinar and this course. She organized all requirements and all of the program has been organized by her. And about the participant, allow me to welcome all of you to this unique virtual gathering and assure you that your active contribution, your ideas, your opinion, your discussions, negative and positive feedbacks leads to us to better and better development of the next series of the webinars. And it is indeed a great honor to me and a pleasure to welcome Dr. Fatma Dedeoglu from Boston Children's Hospital and Harvard Medical School as a speaker of the current webinar and of course the opening course of this series. Dr. Fatma Dedeoglu, basically she is originally from Turkey, and so I tell Günaydın and Günaydın Dr. Fatma, and I think you needless to say more about this introducing you because you have many excellent experience about autoinflammatory disorder, and I think about FMF because of it is a domestic disease in your country.
Yeah.
And I think I have a short notice about the participant. I have short request for participant. Kosar mentioned that please send your questions directly to my chat room, because if you want, they will be available, easily available. Please send your questions to my chat room. You feel free to chat about your comments, about your discussions, but your questions directly should be sent to my chat room. Would you please have a notice to this request? And as Kosar mentioned about autoinflammatory disorder, these diseases are immune disorders in rheumatic disorders, especially particularly in pediatric rheumatology. We face the new disease always, and the important feature of this disease is its inheritance pattern. We will discuss about the autoinflammatory disorder today, and I hope by this course we could gain new insight about the etiology, about the different presentation and classification, and variety of clinical manifestation of this disorder, and of course about the treatment of this new evolving disease in the rheumatic disorder. I'm sure and I promise we will have a marvelous course today. And for the starting of the course, I invite Dr. Fatma to present her topic about this course. Please, Dr. Fatma.
Okay, sorry. Thank you so much. I really appreciate. I can't find. Can you guys hear me? Hello.
Yes, we can hear you.
Sorry, now I can't see all the bottom. I guess that is when. Sorry, it's really. Thank you so much for this beautiful instructions, and this is just an excellent course. I'm really honored to be with you all. Sometimes I speak really fast, and just please, slow me down if you can. You feel that it's just things are rushing. There's so much in the autoinflammatory disease field that has happened over the past 10-15 years that it's just really difficult to discuss individual diseases. So today I'm really presenting the cases that I've been taking care of and what I learned from them and maybe some general information. Yeah, so this is what's happening. All right. So these are my disclosures. I just listed all the references that I've been reading over the years. So I'm just gonna skip these slides very quickly. And I sent some of the more recent ones to COSAR, which helped me to understand. And there are two actually textbooks about autoinflammatory diseases. And I would say any of these authors that you see the names, you can read reviews about the variety of autoinflammatory diseases. And I think today's objectives is to highlight the frequency, which are rare, heterogeneity, and the difficulties in management, and the raising awareness of now what we are calling immune dysregulation, and through doing this through clinical observations. In general, systemic autoinflammatory diseases, if we define them, they are unprovoked systemic inflammation. It can be chronic or episodic, mostly episodic. There's no infectious etiology. They are distinct from autoimmunity because there are no specific antigen-specific T cells or autoantibodies. Most of them are hereditary, but they can be monogenic or polygenic. And the phenotype is so diverse, even in the same disease, that's what makes it very difficult sometimes to diagnose these diseases. And primarily, it's the defect in the regulation of innate immunity. And as we all know, in the past, rheumatology paradigm was autoimmunity, that there were specific antigens and T cells that will stimulates autoantibodies and cytokines, and then the innate immunity is also stimulated and help. But in recent years, we are talking about autoinflammatory diseases, and this is the new paradigm that innate immune system without help of antigen and T cells can act on and create inflammation. This is a slide from probably 10, 15 years ago when I was giving the autoinflammatory disease talk to our residents and so on. And obviously the list has grown over the years, the different, and now it is just, you can read it. So it's very difficult to go each one. And I probably am not aware of some new diseases that's been described the last couple of months, probably. So with many diseases defined and described, now, the pendulum is that we are talking about immune dysregulation, and even some of our autoimmune diseases such as lupus, Crohn's disease, these are considered maybe in the category of this immune dysregulation, and there is a spectrum. Certainly, even in one patient, you may see for all four aspects of immune system mischiefs in the same patient. We had a lot of advances in the genetics and doing studies and biologic studies, signatures, interference signatures, for example, even though it's not available clinically. We still have the patients that we cannot have a name, that we call undefined systemic autoinflammatory diseases, and even in more recent years, the genetic testing has been in our center. We are doing more, about 86% of our patients get the genetic testing done, either whole exome sequencing or limited primary immunodeficiency panels. We still have cases that are 44% considered undefined. So just a brief basic, what are autoinflammatory diseases? They have some shared characteristics, which we call intermittent episodes of inflammation that usually cause fevers, and the organs that are involved the most commonly in many of them, joint symptoms and rashes. And then there's evidence of laboratory evidence of inflammation. And then there are some unique features for these syndromes that will help us to recognize them, such as the, focusing on the ethnicity, inheritance pattern, age of onset can help, pattern or the length of the episodes can be helpful, or specific symptoms for that disease, such as if you have a stroke, you think about certain types. Type of rash can help, urticarial versus non-urticarial rash, or you can use treatment responses in your diagnostic odyssey. And common themes, again, in majority of these autoimmune inflammatory diseases are innate immune system is involved. There's elevation of cytokines, and there's certainly several mechanisms are at play. Again, this is a clinical talk, so I'm not going to really go over any of the mechanisms as much today, but there is certainly a talk between adaptive and innate immunity. And we know that it happens through increased sensitivity to the molecules that recognize pathogens, PAMs or DAMs, and apoptotic ways and protein misfolding. Again, many mechanisms, any disease described, and we learn more about the mechanism of immune system. So I just want to mention about here what is more recently called HAMS, homeostasis altering molecular patterns, because this is likened as if you throw a stone in a lake, you wouldn't see the stone, but you may see feel the waves or so on that's coming at you. So this is how in the immune system or the cells talk to each other sometimes, that as a pattern which is happening with actually pyrin inflammasome at times. And with so much information and categorizing these diseases become an issue again. So using cytokine pathways or immune pathways also has been proposed to use, like as inflammasomopathies, relopathies, or interferonopathies. So I just wanted to again go the rest of the talk through the cases that I followed. This is a patient now, she's 20 years old, but I met her when she was 5 or 6. She came initially with 10 months history of episodic fevers, coming every 3-4 weeks, lasting 1 to 3 days, some headaches, abdominal pain, back and neck pain, and she was well in between episodes. Review of systems, family history, they're all unremarkable. Labs were unremarkable in between episodes. And, I consider she could have PFAPA or another type, or FMF, for example. But then she disappeared for a few years and then came back. This time she had more severe abdominal pain, and her attacks were coming and resolving suddenly. Her ancestry is Italian, Scottish, English, and mom is Italian. Again, the otherwise history was pretty unremarkable. So I decided, being from Turkey, we're seeing a lot of FMF and using colchicine. I do use a lot of colchicine for many types of autoinflammatory diseases. So I started her on colchicine, and she responded very well. At the time, genetic testing was we were doing it with a couple of genes, and she had a heterozygote MEFE mutation on exon 10, which is as we know, the pathogenic mutations are mostly located. And she's been doing really well on colchicine. So she has a single gene. So I still am not sure if she truly has FMF, but she did respond to colchicine. And she has this single mutation clinical patients have been described. So I am calling her FMF. So, but we can always question in a recessive disease, does she truly have FMF or not? So this kind of patient, what I ask is it truly episodic? Are there similar features each time she gets stereotypical attacks, which is very important? Are there triggers? We definitely follow growth and development. You always think about other possibilities in these patients, chronic inflammation. We check for systemic inflammation during attacks or in between. Family history is very helpful, and then always think about alternative diagnoses. This case is also, there's a little bit of a twist on this case. That's why I brought the case up. Came to us with frequent episodes of porphyria since age 1. Sorry, I don't know if, yeah. And this was, his episodes were triggered by stress, trauma, not sleeping well, temperature changes, and then, it would last about 1 week. There will be arthralgias and soft tissue swelling during most of the episodes, and then he had skin biopsy done showed leukocytoplastic vasculitis. He has normal labs even during episodes actually, and then we have a family history which shows similar symptoms in the father and paternal grandmother. And we thought there is some autosomal dominant disease, so we just had whole exome sequencing, which revealed a novel missense mutation in the NLRP12 inflammasome gene, and we thought that would be could explain symptoms. NLRP12 is a very complex molecule, and also the phenotype seems very variable. So it's it's a controversial inflammasome actually, in the sense of causing true disease or not. But when we did segregated the symptoms and the patients and the mutations in the family, it really didn't fit. Some patients who had the family members who had symptoms did not have this mutation. But in the meantime, we also did Lps stimulation, which in NLRP12 disease, you get normal IL-1 levels, but the kinetics would be increased of IL-1 production that's been described in the literature. So we did that, and it really showed the same, like it fit with the NLRP12 phenotype. And at the time I was treating, again, as I told you, I use colchicine a lot. So we treated him with colchicine even before doing all this, when we didn't know what else we could give him. We didn't know what he had. And so colchicine actually caused a dramatic improvement. The whole family is using it and they are doing well on it. But just the twist on this is that we decided to go back as the phenotype and the family member didn't make sense. With this, re-review the whole exome sequencing in this family, and there's a possibility that they might have PLC gamma-2 variant that is the cause of what is called aplate and plate, another form of autoinflammatory disease. So it doesn't really fit into both. These are the cases that it's very difficult which bucket to put him on, but there's a possibility that these two mutations are modifying each other and cause this unique presentation that's very colchicine responsive. And this is, I'm just going to skip for the sake of time, and just to show that NLRP12 is there are some inflammasomes are very complicated, depends on which difficult. So I think, how am I doing? Okay. I think I will skip this case and maybe we'll go back some other time. It's an interesting case, but I'm just going to go. Yeah. So I wanted to talk about this case because it brings me some dilemmas for future. We need to also think about, we see patients as pediatricians, but they're good health, and we live with these future. This case, this boy developed fever and throat at age 7, and he was diagnosed with tonsillitis, treated with amoxicillin and azithromycin. Persistent symptoms required further workup, developed hepatosplenomegaly, pleural effusions, and cytopenias. He was found to have EBV PCR positive, and then his ferritin was elevated, low fibrinogen, elevated soluble IL-2 receptor. So he basically clinically and by lab-wise fit the diagnosis of HLH, hemophagocytic lymphohistiocytosis, which was thought to be EBV triggered. And he was treated with 2004 HLH protocol with a very quick response, actually. He did very well after this treatment, and he had, at the time, only 7 HLH genes were being done or known, and these were normal, and he had normal NK and cytotoxic studies. Then a few months after the treatment, he comes back this time again with fever, but had ankle swelling, and we were consulted from rheumatology. This time he only had slight ferritin elevation, and then EBV PCR was positive again. We diagnosed him presumed systemic juvenile idiopathic arthritis, and then treated him with a short course of steroid, and started him on IL-1 inhibition and methotrexate. So he, with anakinra, he had some skin reactions and couldn't tolerate daily injections, so we switched him to canakinumab. And currently he's, I met him when he's like 7 or so, he's like 15 or 16. He's still taking canakinumab. I was able to space it every 12 weeks. And then we stopped the methotrexate. He's doing well. He never had a flare of his arthritis. He's overall asymptomatic. Occasionally when he has a virus, he gets mild cytopenias. His ferritin goes up a little bit. And then because when new genetics expanded panels are available, I sent those, and then show one of the HLH genes, ITK, variant of uncertain significance. And then I did the larger panel of primary immunodeficiency, and this had some other variants that are all variant of uncertain significance. So for this case, I know these are uncertain significance, but he certainly fits. When I look at ITK, read about it and what it does in the gene or the protein, I feel it does contribute from my limited understanding. But that's why I'm in a dilemma of, when can I stop this treatment in this patient? Can I, because he's doing really well, but I'm wondering if I need to continue long-term, if he has this, if he has another HLH, could he be in a more severe situation? And then when I read about ITK, I see that there's association with malignancies, lymphomas, and could he be more prone to, how do I follow that? How do I do periodic screening? So, and then there are other variants. Do I need to, how do I study those variants? So those are, again, I'm coming with more questions, but this is the approach and how I'm trying to cruise through these patients in the clinic. So this case is also an interesting case that has a diagnosis unchanged after a further workup. She started having mild intermittent mouth ulcers and fever, vomiting and abdominal pain, elevated inflammatory markers, and negative infectious workup, autoantibodies, and with abdominal CT and colonoscopy, she had ileitis, diagnosed with Crohn's disease and treated for that. However, did not follow the course, did not respond, even though inflammation seems mild in her gut, even though she had very high fevers and abdominal pain and vomiting. So she wasn't responding, and she became steroid dependent. She came for a second opinion to our GI clinic, and where our GI IBD specialist recognized that there's something different for this patient and referred to our clinic, autoinflammatory disease clinic. And we did suspect that it could be at the time. And again, you know, any patient gets basically cautious in when I first start. And then secondary, we always think about IL-1 inhibition, since majority of the autoinflammatory disease respond to IL-1 inhibition. So we did those, which was unsuccessful. But she got one dose of anti-TNF in the hospital. We admitted her to have a flare so that we can get her off the steroids. And she, since then, she actually, this has been almost 8 years now, maybe longer. She has not had another episode. She's a dramatic response to infliximab. And I use methotrexate as an adjunct therapy to infliximab just to try to prevent HACA formation. So I think this was, to me, like, we don't see this with arthritis patients. Yes, there's a good response, but like there's always some or this and that. So this me was a clue for this patient having some probably monogenic form of process. And her, we went through post-medical history, really nothing much there, no infections, normal growth, and her immune workup was normal. Family history was interesting. And mom had a diagnosis of Behçet's disease, but with mostly oral and gentle ulcers. And she did not respond to colchicine or other treatments, only for the steroids. And then she had two siblings, which after we met her, they also have some mild intermittent oral ulcers. So we again thought that this is family history is a second clue that we're dealing with something autosomal dominant. So we did whole exome sequencing, and there were 7 variants in the family that were that plausible explanation. And then again, this is to emphasize the importance of clinical observations, how it can be helpful in the at the bench to narrow down your search. So the fact that we had that TNF response, anti-TNF response, we hone on this REL-A molecule because of that, just the association. And then further workup certainly showed that in the patients, the REL-A, there was haploinsufficiency, there was 50% decrease in REL-A, wild type REL-A. So again, for the time's sake, we published this in 2017. So with collaboration, and this is also tells us the importance of collaboration with our basic science colleagues. So we were able to show that there is the decrease in wild type REL-A, and due to alternative splicing of this. And just to summarize all this busy slides, that there's increased cell death in fibroblasts. The mostly affected are the stromal cells, and decreased NF-kappa B activity, and PBMC is not affected. And decreased NF-kappa B causes anti-apoptotic protein being decreased, therefore more apoptosis happening, and of REL-A to these the mice studies. So and if you inject TNF, you cause also
Koser?
I think we have a problem. Yeah, Dr. Dedeoglu.
Interruption. We have some interruption. Dr.
Yeah,
Fatma,
Dr.
please stop.
Dedeoglu.
Yes.
Oh, okay.
Please stop. We have some interruption.
Can you hear now?
Yes. I think we had a problem with your voice, dear Dr. Dedeoglu. Can you please talk again so that we can check if everything is okay? We still don't have your voice.
How about now?
Oh, we have, but I think there are some interruptions.
Oh, I don't understand. I have the
No. Now it's
Please
okay.
go case 5. Please go for case 5.
Case 5? Sorry.
Yes, please.
Okay.
Case 5.
Case 5. Okay. Let's see. How do I do that? Okay. So should I start from when did you stop? Like, is it?
Well, we had your voice, but there were some on and offs. There were some interruptions. So if you could just explain it again a little bit.
Okay. So let's see. Sorry, case 5. So this is, I don't know how much this is a patient who has initial diagnosis of Crohn's disease, and then and then we thought that she had a monogenic form because of her dramatic response to TNF inhibition.
Sorry, Dr. Dedeoglu, we cannot see your slides.
Am I not sharing my?
No, you're not now.
Okay, sorry. Oh, is this? How about now? Can you see it?
No.
Oh. Let's see.
We'll be okay soon.
If I do share screen again, sorry, I'm not. I get really nervous about these.
It's totally okay. Yeah, now we can see it.
Can you see it? I'm sorry.
Yeah. Thank you. Thank you very much.
Okay. Somehow
I think we have enough time. Don't worry. We have enough time. Yeah, we have enough time.
Okay. I have quite a few. I have like double this amounts of slides. Sorry, I just so much information. Okay. If I do now, I don't even know how to do the slideshow. Because when you share, it's hard to go back to do the slideshow. So I think I should do this slideshow.
Yeah.
Let's see. What is this thing? No, thanks. Okay. Is this fine? Okay, can you see? Oh, well, you see my side slides too. I don't know why it doesn't.
Yeah, that's okay.
Now it is okay?
Oh.
Yeah,
totally that's okay.
Yeah, okay. So this is again, I sent Kosar the paper on this, so for the details. But basically, I think the reason I brought this case, even though it's published several years ago, is just that I want to emphasize the importance of clinical observations, and as clinicians, we see these patients all the time, and our observations help hone in things. That's why this patient had a diagnosis of Crohn's disease, but did not respond to the Crohn's disease therapy, or even if we thought about autoinflammatory disease, did not respond to colchicine and anakinra, and a very dramatic response to TNF inhibitor. And then there was a family history of these similar oral ulcers and gentle ulcers with the diagnosis of Behçet's disease in mom. So that was our second clue that we are dealing with monogenic form of disease. And further workup with whole exome sequencing revealed that there are some candidate genes, but we focused on REL-A because of the clinical observation that we have that TNF toxicity should be playing a role with a good response to anti-TNF therapy. And then basically these basic science slides, after a couple of years working in the lab, we were able to show that this defect affect mostly the fibroblast, which cause increased cell death in fibroblasts with more sensitive to TNF. And there is because of decreased NF-kappa B activity that is causing the decreased anti-apoptotic proteins, and this is restored when RLA is transfected to the fibroblast of the patient's cells. And then we had a mouse model showing that injecting TNF with RLA haploinsufficiency mouse, heterozygous mouse, creates a homozygous don't live. So that causes an ulcer on the skin, and it is through fibroblast. Again, it is directly not hematopoietic stem cell. And we also showed that these mice develop a very severe form of ileitis and colitis, and they respond to anti-TNF therapy. So, and then this is the paper that has more details on it. So, sorry about all that. So I'll just collect myself a little bit. So this case, I saw this patient several years after we had described REL-A, and then she came with recurrent fever, severe abdominal pain, vomiting 2 weeks since infancy, and had a lot of workup done, inflammatory markers, negative endoscopies, some aggregates in the colonoscopy and endoscopy, elevated calprotectin. He did not have any oral ulcers, and he had normal growth and development. So this case basically, and also in his past history, he also did not really respond to colchicine much, did not respond to anakinra, was having breakthrough episodes. So that, you know, just listening to the story, and then by the time we saw him, he actually was started on etanercept, and he had again dramatic response. So seeing this, I thought maybe this patient also has relay positivity, and then we sent it genetic testing, and it ended up being so that helped me to recognize this patient as well. And then for relay, it is interesting that there's also another publication from NIH showed a 5-year-old who had a diagnosis of autoimmune lymphoproliferative syndrome with typical features of autoimmune lymphoproliferative syndrome, but their workup also showed relay haploinsufficiency. And you know, the explanation, this is a very different phenotype, is that the patient had other variants in other genes, especially they thought that it is in the NF-kappa B regulator genes that there were some changes that may be altering the phenotype. And then after this, we've seen a few more patients with relay similar to our cases. And then there's one described from Ireland actually recently. Okay. And then is it okay, continue with cases?
Yeah, of course. Go ahead, of course. Wonderful cases.
Yeah, I think I mean, these are, I choose these just because it highlights different aspects of how we approach. That's what I am bringing them. But this case also is very interesting and surprised me with the final diagnosis. So this is a kid who's age 5. He was diagnosed with rheumatoid factor and CCP positive polyarticular arthritis. I think this is, you know, first of all, that is something that we should pause, right? It is very unusual to have a 5-year-old male to have both rheumatoid factor and CCP having polyarticular JIA. So he did though respond to methotrexate and, you know, classic treatment. So yeah, that's fine. But, you know, we always have to kind of put that in the back of our minds. And then, you know, family history was also with sarcoidosis. Father had it, and paternal great aunt had sarcoidosis diagnosis, and they both actually passed away when age 30s, young adulthood. Because of that, actually, when we met him at 5, we did not do genetic testing for Blau syndrome or early onset sarcoidosis question. And just as a caveat, whenever I hear a sarcoidosis diagnosis in the family history, I always think about immune dysregulation, is because the kid, you know, if it's not a classic sarcoidosis presentation, especially CVID patients and so on. So that also made me to keep thinking about this patient. Then he didn't come back for 5-6 years, and then he came back with the history that he was having worsening atopic features over the years, with a lot of rhinoconjunctivitis, like really bad rhinoconjunctivitis, vernal eczema, and requiring IT immunotherapy. Then he developed this lesion on his eyelid, and the biopsy was done somewhere outside. And then they questioned, oh, because there's family history, could this be sarcoidosis again? So because we do rheumatology, dermatology combined clinic, so he was sent back to us to see both of us in there. We had ophthalmology look at him. They just said this is all, his skin was atopic dermatitis. He had vernal conjunctivitis. At the time, like shortly after that, actually around 14, he started having shortness of breath and exercise intolerance, and then had a chest CT, which was suggestive of ILD. So he had lung biopsy done. There was a lot of inflammation, not typical for anything, but a lot of inflammation. And then, again, going back to family history, father's history is that he had arthralgias, rashes, respiratory symptoms, and then he passed away from brain disease, some type of progressive multifocal leukoencephalopathy. I question if there's immunodeficiency that wasn't recognized at then. And then I found father's aunt's history. I got records from 1953s and went through them, tried to understand what this family has. And obviously we said, there's definitely, and it's very scary, especially for the kid and mom, that she was so scared that her child is going to die like his father and the aunt. So we decided to send okay, I mentioned a little bit of physical exam, really had conjunctivitis, some chronic changes of polyarthritis, but his arthritis was good control. He did have clubbing, certainly he had lung disease. And very elevated inflammatory markers, and also he had multiple autoantibodies. Again, that's suggestive of both celiac antibodies. You can give any disease to him, or thyroid antibodies. He had low complement, so he didn't really fit anything particular. So again, suggesting we need to look further. This is his lung biopsy results, and how his lungs look, all the cystic appearance on the sides. And then we thought could adalimumab cause any of the issues. We stopped that, started steroids and azathioprine, and at that time we did send whole exome sequencing, considering that we might have something new, that autosomal dominant. And then for the first time around that time, it was a winter time, he developed vasculitic lesions on his foot. As you can see here, it's now very well done. At that time we tried to treat it with colchicine and then dapsone while waiting for the VES with some response. And then the result of the whole exome sequence was very surprising to us, because he had a mutation in STING, stimulator of interferon genes, with the classic mutation V155M. So years later, we were able to give him the diagnosis of SAVI, STING-associated vasculopathy with onset in infancy. And this in SAVI, usually actually skin symptoms starts in infancy, and lung symptoms start in infancy too, with acral purple violaceous plaques, nodules on the nose, ulcerative lesions, and livido, Raynaud's, telangiectasia. He really did not have any of these until when he was like 14, 15. And then joint findings generally happen later on. But I think we are certainly recognizing now there are many patients who have different phenotype, meaning the symptoms start in different times. And a poor or partial response to steroids. Now we know that, again, I'm not going to go over the STING pathways, but patients were responding to JAK inhibitors because of those pathways that we know. So we decided to give him a JAK inhibitor. So there are two reasons I chose tofacitinib. Mostly baricitinib is used when the NIH cohort, but because it was easier to obtain insurance-wise. And also I thought about JAK3 inhibition in him because of his atopic signs and symptoms, since that is more on that pathway. So after starting him on tofacitinib, 5 milligrams twice a day, he was off all medications, and even his lung disease improved, which is not actually, it is difficult to reverse the lung disease. And interestingly, he was able to stop his immunotherapy, all atopic signs disappeared, he was doing very well. And we also published this case. Let's see, time-wise. Okay, I think I will, maybe I'll go to, I'm just going to skip these cases. Maybe, at any point we can come back later on or so on if he wants to, because I think we should probably talk about a little bit of just kind of go over things, what we should be doing, or if you guys want to stay with the cases, I'm fine too.
Dr. Fatma, we have enough time. You can you can speak about our more cases.
Yeah,
it's okay for
I think,
us.
I just that each one kind of emphasized like some of the things that we don't want to give up. Like this case, that reason I brought this again, one of my patient that. When I first met her, she came with just 6 weeks of polyarthralgia, polyarthritis, morning stiffness, ANA positivity, but had severe leukopenia at the time. Past medical history was unremarkable. The family history had some autoimmune conditions, and father died of leukemia, and half brother had lymphoma, and then 2 of mom's nieces had leukemia. So that just I just kept that in mind. But I saw her; she looked great. Except that she had this low white cell with lymphopenia, which, with autoimmune conditions in the family. I said, I need to watch this girl, but let's treat her arthritis. Maybe it's post-infectious with some NSAIDs. And she really responded very quickly, did very well. She had some uric acid elevation and LDH, so hematology evaluated her and had bone marrow biopsy even at the time. Then 1 year later, she's doing okay. She falls, and then all of a sudden, her that they did, because she had hit her head. They checked her CBC, and then again, she has thrombocytopenia, and ANC is low, elevated inflammatory markers. So the concern was Evans syndrome. This time ANA is negative, but some anti-neutrophil antibodies are positive. And then 6 months later, things improve. By that time, I didn't even see her, followed by hematology. And then, this is how her counts were. The follow-up platelets improved, but she remained leukopenic, both lymphopenic and neutrophilic. And then, as you can see, her monocyte count is also low, which I did not really pay attention at the time. And then 9 months later, she comes again with joint pains and some, like she fell or had some issues, so they had to be admitted. She had some confusion, so found to have EVV encephalitis and some rashes. So rheumatologist again was involved in her case, and I followed her, and then I decided these are all strange things happening here. So I went back, I saw her 3 years ago. I didn't connect the dots then, but it's really important to go back and look at what is done. I already did her. I started thinking about GATA2 deficiency because we had another patient, young girl, who presented with HLH type of picture or macrophage activation syndrome. Looking at her GATA2, how it presents, I realized that she might have that because of low B cells and NK cells, B cells, and then also a very high switch memory cells and low monocytes. So I decided to send the GATA2 gene, and I actually did a single gene because I was pretty sure she has that, and then she did have it. One of the things I think we need to think about psychological effects of these, what we do. GATA2, sometimes I think about, did I do the right thing in finding this now? Because she went through, she couldn't decide if she wants to do bone marrow transplant or watch. It's very gray area in immunology, which I wasn't aware that much. I don't know if she was as happy because she found the diagnosis, but then with the decision, it was very difficult on me too, to how we approach these patients, and diagnosis is not really easy. So I think this is going to be my last in terms of cases. These are the twins, and I brought this case to emphasize the importance of collaborations and not holding on our data and just to share, and so that we can have better treatments for our patients. These are identical twins. Who one of them has more severe, the other one has milder form of presentation, but the severe one started having recurrent fevers, and then fevers went away, but started having aphthous ulcers and the terrible skin rashes. The rash biopsy showed neutrophilic paniculitis. So colchicine again responds to for recurrent mouth sores, responded to that, but his rash was required requiring both topical and systemic steroids. And then he also developed this lipoatrophy. He's been having poor weight gain, elevated inflammatory markers, concerned about GI. And then at the time, I sent limited periodic fever panel, which was only available then. He had some variant of unknown significance in TRAPS gene. I thought maybe this is what he has, the lipoatrophy, muscle, the rashes, everything it could be, but I wasn't sure. And I treated him with IL-1 inhibition with partial response. And then, twin brother identical start having similar symptoms. There is some vague family history. So I said, let's send chromosomal microarray to see if I'm missing something in this kid, because whole exome sequencings, you may not pick up the deletions or additions. So the chromosomal microarray, I actually got a call from lab that he had deletion on the X chromosome, and both siblings have, and where ELF4 gene located. At the time, this was several years ago, it wasn't well known. This is very well studied in mice and so on. I know it's a very interesting molecule that I'm still learning. And then because of mouth sores and he's just steroid dependent, I decided to use apremilast. He couldn't really tolerate the higher doses because of GI side effects. Currently, I'm considering anti-TNF therapy, and just recently, and this is just again, I'm having a hard time, but ELF4 is again in the center of STING, interactions, interferon pathways, and it involved in NK cell development, perforin expression. And then this article just came out about 3 cases of human autoinflammatory disease with similar, but not exactly to my twins. And they described neutrophilic infiltration, elevated IL-17 because macrophages are hyper responsive. I'm thinking this is, it's a good case. If we had known each other and so on, we could have combined our, that would have been very nice to, because I'd been struggling how to treat these kids with steroid dependency. But apparently the TNF would be an option. Every kid in this 3 case series was treated with different things, IL-1 inhibition, IL-23, 12 inhibition, and IL-17. So I'm considering maybe I'll do those. So I think there's more of just a go over general when we talk about when we see a patient with fevers or recurrent fevers. As we all know, we have to think about all other possibilities, making sure we rule out all those infections and IBD. That's why the history is very important, especially for recurrent. You always want to look for stereotypical episodes, age of onset, if there's symptoms in between or kid is growing, how many days, how often do they occur, and associated symptoms as obviously family history and ethnicity. Detailed physical exam, vital sign, definitely making sure taking pictures. I always encourage families to take pictures, the mouth, the skin, and examine full exam. I don't think I had to tell the group of rheumatologists about this, but labs are important to do, especially we are dealing with episodic, making sure during and in between, and looking for neutrophilia, thrombocytosis. And then we can think about specific testing, genetics, depending on situation, full panels, or this is debated, should everyone get whole exome sequencing, which I think that should be the case, but we always have to think about what resources are available, and still we want to use our clinical judgment and skills to be able to hone in maybe the diagnosis without unnecessary testing. Specific testing, urine mevalonic acid, for example, would be very helpful during an episode for mevalonate kinase deficiency. Ferritin, skin biopsies, I didn't bring that case, but that helped me calling someone genetic testing negative cryopyrin-associated syndrome if I see typical skin findings such as neutrophilic urticarial changes. And then when we deal with autoinflammatory disease, we always have to think about the complications, even if intermittent episodic situations, there can be severe complications. One of them is amyloidosis, as you all know. And that needs to be monitored for this, especially certain types. Macrophage activation syndrome, even milder form diseases, for example, mevalonate kinase deficiency is a relatively mild form, but they are more prone to developing macrophage activation syndrome. And other things, I usually have most, especially undifferentiated patients, I have their hearing checked periodically, visual exams, monitor for CNS involvement, and considering their quality of life. And how do I do these monitoring? Growth and development, blood counts, inflammatory markers, proteinuria, again, hearing checks and neurocognitive checks. You probably are aware, this is ADI is autoinflammatory disease activity index that has been validated for 4 of the main periodic fever syndromes, which we're also trying to do that for PFAPA, but that can be used in for disease activity. So in terms of how do we treat, sometimes treatments are helpful to hone in, as we discussed, of maybe the pathway, but it can range from symptomatic therapy, or you do a blanket approach that's just using steroids and colchicine. You can do targeted approach, anticytokine, or any of the combinations. So this is it is impressed. We looked at our cohort of patients, about 133 undifferentiated patients who we use colchicine, and most of them actually responded, at least partially. Non-responders were very little, and from this limited cohort, we found that if you have rash, it predicts that maybe you will be less responsive to colchicine, but needs to be validated, obviously, with larger cohorts, especially if you have non-urticarial rash. And then there's another study from Papaya also showed that the colchicine response is good in undifferentiated patients. So that would be my primary go-to medication in patients who I don't know what they have exactly at the time. And then with the cryopyrin-associated periodic syndrome, the description after gene found, IL-1 inhibition obviously create a big difference. This is one of our patients actually that pre-treatment on anakinra and then withdrawal phase when she was in the trial shows that anakinra is very effective. There are a lot of resources coming up from Eurofever about recommendations how to manage autoinflammatory diseases. Again, I think they're all honing on to collaboration. So I really want to emphasize that. Okay, so unanswered questions, sure. Anytime you have something new, there's always unanswered questions. I'm just going to put all of them. There are autosomal recessive diseases, one mutation with symptoms, variable penetrance in the family. What is the role of other modifier genes? And adult onset form of autoinflammatory diseases, as we know, somatic mutations happening over time, and adults can present. So that's why it's important to think about these diseases in adults as well, and modifier genes. And then I think there are a lot of challenges due to the rarity. Again, that's why it's very important to collaborate. It affects many organs, immune system, inflammation, and it is very variable even in the same family. So it's hard to connect the dots even in the family sometimes. It can mimic many other conditions. The response to treatment is different even in the same pathway. And the genetics and environmental role we need to work on. Other obstacles we face day to day, I'm sure it's the same, availability of medications, insurance approval, access to care, and you can describe a condition, but if you're not going to deliver, then what is the good of that? So we really need to address these difficulties and patients finding the specialist or school, lack of awareness, people not believed in, which I think Karen from Autoinflammatory Alliance will be talking some of that in the coming weeks with your group. I think we discussed these. I mean, also with some trying to stop the treatment, as my cases show you, some of them, I don't know when to stop, because, still committing someone to lifelong medication, maybe it's not necessary, is difficult. And these unknowns also makes us like, what is better, to keep going with the drug or stop and see what happens. And monitoring for other immune-related issues that may come up. I think just a few slides to finish up. Kind of summarize, AIDs are due to errors in innate immune system and cause unprovoked inflammation, multi-system disease, and inflammasomes and IL-1 seem to play a major role. And monogenic forms are rare, but we know that pathophysiologic mechanisms are common, so we learn a lot from these conditions. So suspect autoinflammatory disease when you see unexplained fever and rule out malignancy and infection, and if there's persistent recurrent systemic inflammation, or there are some stereotypical episodes and also associated features that seems that is a possibility, such as basal ganglia calcifications is the typical for interferonopathy, some of them. And try to recognize the pattern by looking at the family history. For example, hyper-IgD syndrome, how many days, where they are from. For TRAPS, associated features, and for DADA 2, early onset strokes, these are kind of the patterns that may be recognized. And do some testing to exclude other things, specific testing, and then try treatments. As we talked about IL-1, TNF, JAK, colchicine, and really follow the clues. And what is important is most of these patients require multidisciplinary care, and rapid disease control can help prevent long-term organ damage. And we need to also try to address their day-to-day living and to improve their health-related quality of life. So it's all shared decision-making together with the families, patients, and all the caring team. So I think I'm going to stop there. I was going to go over like a little bit hits and traps, but maybe we'll just I think I want to start with this. This is I'm just really clinical observations are very helpful. And this is from Dr. Still's thesis. He was able to describe in 1897 a JIA, that's how we know it today, that it is a heterogeneous disease and the absence of pain is generally striking. I think we still don't have much more information than he had with his observation. I mean, obviously we do, but so I just, with good observation without having any other tools, you can actually still manage patients. That is what we all do in the clinic day to day. So just want to thank my group here, many collaborators and working together in pathology and all the other the programs, our fellows and our program that supports me. Thank you.
Thank you very much, Fatma. Wonderful presentation, wonderful case. Thank you very much about sharing your cases, your knowledge with us. We have so many participants, but I didn't see any questions in my box, but it doesn't make sense because I have so many questions. If you're ready, I put my questions and discussions, okay? Dr. Fatma, we have a background about the mutations and inheritance of this autoinflammatory disorder. Background is mutations. And we know today about the familial Mediterranean fever. MEF genes had a protective rule against the plaque. These mutations protect the human body from the pandemic of the plaque. What do you think about the other inflammatory disorders? Are they protective mutations or just incidental mutations we have in other autoinflammatory disease? What do you think about, for example, hyper IgD syndrome? Is this mutation as a rule in protection against some unknown disease?
Yeah, I mean, I think that raises a very good question. I was thinking about hyper IgD actually because there is this discussion about exposure to saturated fat, and then with that mutation, you may be more protected from metabolic effects of inflammation. But I don't know, I haven't looked into that as much, but there's certainly, we know that it's a metabolic pathway and it triggers actually pyrine inflammasome. Now we know that hyper IgD syndrome or mevalonate kinase deficiency go through. So I agree with you that I'm sure. And the question is like, how do we, it took to understand what pyrine does, it took like many years. So I think we still need to kind of think about how to study these. The
background.
Yes, exactly. Yeah.
The background of the mutations.
Yeah, exactly. And for data too, for example, it is very common in certain populations too, like there's a Finnish kind and so on. So we don't know why that guy we need to, and it's like E148Q is more common in Asia for FMF,
The second questions, I don't have any questions from the participants, but I have to share and I have to put my questions and okay, no questions. My second question is about the ethnicity of the disease. How many patients do you have from Black or Hispanic Americans in your clinic?
Yeah,
I think if these autoinflammatory disorders belong to human, why we don't have these disorders among the Black, among the Hispanic, among the Latin American people?
Yes. So yeah, you kind of like hit the nail in the head, as they say. Like this is one of the things that, like when we looked at our cohort, we talked about PFAPA and so on. It is very common, like it affects all. There is no ethnic or race preference, but we only have like one Black patient in our cohort of PFAPA. So that is just a very, very that's a like we're talking to our group and the Boston Children's, like what is the why is this happening? So there's definitely access to care, like how they're like, are they not being picked up the same way, through the pediatricians? Where is the problem? There's a problem. That is for sure. There's a problem too. That's for sure. And we need to really address that. That's why I think these things affect me, especially with this pandemic and so on, a lot. Like what we're doing here, we can describe all these things, but like we need to deliver what we know, or like to everyone equally. It's just very I really like you. I'm just getting emotional about this because it's very important.
Fatma, do you think about the environmental factors, like the modernity of the society and industrial environment factors about these mutations? Do you think they have any rules in these mutations? Because north part of the Europe is a modern country, is industrial countries, but the African people and Asian people, we don't have the same industrials. What do you think about the environmental factors and these mutations?
I mean, I think, there's definitely some studies showing environmental factors affect the phenotype for sure. We try to look at with FMF, like looking at microbiome with a very small group of patients, like comparing Turkey and the States. We didn't really find much of difference, even though there are differences in the microbiome not related to FMF. So I think, there must be, right? It is because even in the same family, like it's not just a gene, they have the same mutation and the phenotype can be so different. So what other exposures you have, what other modifier genes and so on, this is, these are not very easy to study. I think that's why, but like I feel maybe we need to, like systems biologies and all these are done, which I am having a hard time why we cannot connect these dots easier, but it's just, it's not the gene, how long the protein stays in your cell, in which cell it is, like what other exposures you have. From clinically, we know, I had a patient who had a mild form, psoriatic arthritis patient, had a mild form of MAS because at the time she was on sulfasalazine and then mono infection. So I thought that is causing, like that the combination caused her have this mild MAS. I tried to look for what is different with her, like, none of my psoriatic arthritis had. So there must be some like if she only had sulfasalazine or there's maybe mono wouldn't have caused this, but the combination made a difference. So yeah, good questions, but I don't think I have.
Yeah. Usually good questions don't have good answers. Fatima, what do you think about the malignancy and the relationship between malignancy and autoinflammatory disorders?
I think the molecules that are central to the immune checkpoints and controls are actually in like STING, like NEMO. Those are my kind of favorite. So they are also in tumoral pathogenesis. So, but I don't know if I looked at it like you're saying, maybe autoinflammatory disease patients may have less likely to develop tumors. Is that or malignancy?
Malignancy, besides the lymphoproliferative disease, other malignancy. Is there any relationship between autoinflammatory disorders? Is a predisposing factor to malignancy?
I'm not aware of, like, because we don't see it in our patients, but like it's dealing with, I don't know in the adults actually. But certainly the molecules like STING and NEMO who are like the anti-tumor immune the proteins, they are involved in some autoinflammatory diseases, but I think it will be difficult to generalize it because there's so many different mechanisms that
malignancy and autoinflammatory disorder.
Yeah, exactly.
Yeah. Fatima, when we are talking about autoinflammatory disorder, we are talking about the innate immune system. Innate immune system in human is and in mammalians is an old part of immune system. We have very similar disease in animal models. What do you think about the animal disease, about autoinflammatory disease between the animals? Do we have a similar disease in animals?
There's one that I know is chronic recurrent multifocal osteomyelitis, like CNO. There's a dog. There are dogs that get them, but I'm not aware of other ones.
About FMF, I think we have FMF in some kind of dogs child pie. But about the other disease, autoinflammatory disease, I don't have any idea.
Yeah, I haven't looked. Yeah, you're right.
Fatma, it is a misunderstanding, I think. It is my idea. When we are talking about the autoinflammatory disease, we are talking about this immune regulation, an innate immune system. But some part of this immune regulation is not immune regulation, especially when we are talking about the NF-kappa B pathway. We are talking about the cell survival pathway. When we have genetic and hereditary disorder in cell survival pathway, the outcome is autoinflammatory disorder. The basic mechanism is not inflammation and this immune regulation. I think this is not good nomenclature about the autoinflammatory disorder. The best nomenclature, the best name is non-metabolic cellular dysfunction syndrome. Non-metabolic because it is not the metabolic pathway. The best name is non-metabolic cellular dysfunction syndrome, but the outcome is autoinflammatory. Are you agree?
Yes, I think that is good. The terminology that's definitely good not to stick with one thing, because the more we know about things, then we change the terminology. And I think there's a question on the chat about the ANA positivity in patients. One of my patients, like I actually, a few of them, in autoinflammatory diseases, what are called autoinflammatory diseases, their autoantibody development happens too. So like the SAVI patients develop, Candle patients develop autoantibodies. I think that the same way immune deficient patients, they develop autoimmune features quite often. That's why the immune dysregulation part comes to cover. So like PLCG2 gamma deficient patients, they develop allergies, they develop the immunodeficiency, they have autoinflammation, they have all features of the immune. I think that dysregulation may be a little bit my kind of English. That's what to me it describes. Like there's some dysregulation. It may be coming from metabolic pathways. It may be coming from but it's causing this dysregulation. Maybe you can say cell, as you said, like instead of taking away the immune part, there is some dysregulation going on.
I think you answered a question that my colleagues asked about the mixed type of polygenic disorders such as SLE and BEJA. You answered this question by two spectrum of disorders: innate immunity, this sides, and autoimmunity, other sides. We have mixed type of disorders in between these two spectrum. The question was, why we have polygenic disorder?
Why do we have? I mean, I think I will turn around and
which
say,
one is dominant? Which one is dominant?
Yeah.
When we have a polygenic disorder, which side is dominant? Which side is background to other side?
Yeah, that is, I'm not sure how we can answer that. It's just almost like 10 people pulling out the rope. And then if you're some sort of a balance, then you wouldn't know whose strength is contributing. Like you can't tell from just looking at, like they may stay still in that position. But it's possible that one of them actually holding the whole thing. And so it's just like that. I guess it's, we need to kind of understand how to walk through those 10 people, like to measure their strength or how much they're pulling and so on. Like, I think that is the way to go to understand the balance.
Yeah. Thank you. And question about the age and autoinflammatory disorder. Is a limited age that we consider this disease in people and patients over 50 years old. We can thinking about autoinflammatory disorder, or just the young people and kids and children.
I mean, I think for older, again, I don't have a lot of experience with the older adult patients, but from my colleague who I work with, Dr. Hausman, who's an adult and pediatric rheumatologist, I mean, he certainly sees patients who come to him. We know that in adult, like age 40, age 45, some of them have like 4 or 5 years of symptoms. Some actually lifelong. Like I have families, I diagnosed the child, and then all of a sudden, whole 3 generations, they say, oh, I had the same thing. They start using colchicine, everyone gets better, feels better. I think they've never been addressed. Autoinflammatory Alliance, actually, they did the surveys with the families, like how long does it take for them to diagnose and so on. There's a lot of delay. So I don't know if that diagnosis age tells us exactly when it happened. As far as I know, like FMF, it can get better. Like you may even stop your colchicine maybe when you gauge 40, 45 or 50, the older age.
Yeah.
We know mevalonate kinase deficiency gets better, the episodes. But asking patients, the surveys, they still feel, now for PFAPA, we talked about feverless flares. Like people, even if you take tonsils out, even if you treat the fever, sometimes they have these, I have a patient, 14, 15-year-old, still we call them PFAPA. I don't know, maybe he has something really different. But he's having these episodes still, no fevers, like he doesn't have the fevers, but that's just a part of it, and it still affects his day-to-day, it impacts his life. Those are difficult to understand to, adults. They're hearing that they were told crazy.
Like we don't have in older age.
Yeah.
Thank you very much. And Fatma, it is my last question. 1 century ago, Ehrlich wrote about the horror autoinflammaticus, autotoxicus. And recently, Kastner wrote horror autoinflammaticus. And what do you think about the future? Where are we going to this autoinflammatory disorder? From horror autotoxicus to horror autoinflammaticus. What is the last step in this journey, in this course?
I don't know. Terminologies are always difficult I'm not sure. I think my wish, I don't know, this may be not doable. Maybe we need artificial intelligence, something that, like, I really think the answer is in the understanding those interactions. And I feel like as clinicians, we actually do the personalized medicine with the patients in a way, not maybe knowing, but like just with these observations, what they respond, what else is going on in their life, because a lot of other things affect their life. One ideal treatment plan may not be ideal for the other person because of some other reasons. And those are effect because definitely, we all talk about stress triggering these episodes, but no one really looked at it very, it's almost anecdotal, but we know that happens. Birthday parties and holidays and so on, these things, they happen. So all those things are important to put in the equation in terms of both understanding and kind of finding the path. So I will say that as clinicians, we do try to do this day to day with each patient, taking them as individual and treat them.
Thank you very much. I think we are nearing the end. No questions here. And thank you very much about your wonderful presentations, wonderful cases. And I think, I'm sure we had a wonderful and marvelous course today. I'm going back to COSAR about the other colleagues' questions and comments I don't see here.
And I'm happy to answer anyone. Like, you can give my email, and
Okay.
you know, I'm happy to discuss and so on if any questions come up. As much as you know, it's a field that's I don't like. It's very hard to keep up.
Thank you very much, and I hope a lovely weekend for you. And again, Merry Christmas and Happy New Year again to our participants. Kosar, do you hear me?
Yeah, of course. Thank you very much. Yeah.
You're welcome.
Thank you. I sincerely thank Dr. Salehzadeh and Dr. Dedeoglu. Thank you very much. Collaborating with you both has been an honor for me. And dear Fatma, thank you very much for your fabulous lecture. We are very grateful for the cases you shared. And we surely look forward to learning more from you soon. Also, I'm grateful for participation of all of you academics in the first session of How I Treat Autoinflammatory Disorders course. I hope you have had an enjoyable time. I shared the articles for further reading on the subjects discussed today in the chat section, and they also can be found on the website as of tomorrow. We will share the post-test later with the participants, and then we can send the certificates. As I mentioned before, the certificates are approved and validated by APLAR, Pediatric Rheumatology Society of Iran, Iranian Rheumatology Association, and Tehran University of Medical Sciences. Our next session will be held on January 21st, same time as today, 2 p.m. GMT, after pause due to the holidays. And you can find the details on the next sessions in our website, and you can see the link in the chat for room. I will just put it here in the chat for room. And also, we will be very grateful if you can fill in the feedback form before in the chat for room. And thank you very much and have a great day. Thank you again, Dr. Dedeoglu. It was a great pleasure to meet you here today, and it was a great lecture. And thank you, Dr. Salehzadeh. It was really great.
Thank you. I enjoyed it so much too. I really appreciate, and thank you.
Thank you. Thank you very much. I will just put the website link here. And have a good day. Goodbye. Bye.